Okay, Assalamu alaikum, good evening. My name is Ibrahim Sbeih, and I'm a neurosurgeon, and we are transmitting live to our international audience from Amman, from Prof Medical Campus. Our topic for tonight is about cranial joint hydatid cyst. You may wonder why I put this dark drop slide. I'll explain that later, but basically this is Ibrahim trying to slaughter his son Isaac according to the religion story.
Half a smile?
Yes, that's right. Hydatid disease is a major problem. It is endemic in certain areas, and we are one of the areas where Hydatid disease is prevalent. So we're talking about the global burden of Hydatid disease. It is common in children and young adults, and mostly male young adults. And cyst, any cyst, whatever it is, takes several years to grow to a large size. So we're talking about this, and we're talking about our case, which is like this. Remember that this cyst is made of three layers. This is the layer, the brown one, related to the host, i.e. if I have Hydatid disease, this is the layer formed by my body. Around these two layers, the laminated layer and the germinal layer. This is a major paper about Hydatid disease from China, about patients between 1996 and 2010. From 58 hospitals, 21,560 Hydatid disease. China is one of the areas where disease is endemic, 80 per 100,000 persons per year, and out of these, 45 patients had Hydatid in the brain. So it is a major global problem. And in the same time, from the same paper, the 45 patients who had brain Hydatid, they operated on 21 males were equal to females, almost age young to 61. 4 were children, and 20 cranial Hydatids, as you said, supratentorial were 13, infratentorial were 7. So spinal Hydatid is less than cranial Hydatid. So I'm going to call upon Dr. Untitled to start the discussion.
Thank you, dear Dr. Ibrahim. Good evening and welcome to our international audience. My name is Sbeih. I'm an infectious disease doctor. And Hydatid cyst is caused by the larval stage of tapeworm Echinococcus, most commonly Echinococcus granulosus, encountered in various parts of the world, especially those with sheep and dogs. And the life cycle illustrates how sheep that eat dog poop containing eggs develop the disease, and then dogs that eat the remains of dead sheep or goats develop the disease, and man is an incidental host. And so if a human consumes anything contaminated with dog feces, then they can catch it. There are 6 species. 4 most commonly, Echinococcus granulosus is the most common, causing cystic echinococcus, the subject of tonight's talk. E. multilocularis causes alveolar echinococcus. E. vogeli and oligarthus are more in Latin America, and there are 2 recently described other species, just for our knowledge. How does it present clinically? Sometimes it's just an incidental finding, an asymptomatic patient as a cyst by the radiologist. It can be a space-occupying, simple or complex cyst, may present with mass effect, example on the portal vein or on the intrabiliary ducts, intrahepatic biliary ducts. Liver alone is affected in 75% of the time, and 25% liver plus other organs. When let's say we swallow the embryonated eggs and they hatch in the intestine, they go first to the liver. And then they can disseminate locally and spread locally to the lungs, heart, or to the spaces of the mediastinum, pleura, or pericardium. And I'll try to show you some examples from my patients. Or disseminate hematogenously to the brain, kidneys, muscles, even bone and spleen. They may present with an anaphylactic reaction when they rupture or leak. The cyst could secondarily get infected or have a bleeding. This is a 26-year-old female who is hemiplegic, second as an RTA. Very ambitious, wanted to continue her studies in England, so she presented for a physical exam, and part of her routine is the chest x-ray, and below, behold, she has 3 big hydatid cysts, completely asymptomatic. As a child, she has been raised on a farm in rural Jordan, where there were plenty of dogs and sheep. This is a 24-year-old male that was otherwise healthy and presented with vague abdominal pain, and his CT showed a big hepatic as well as a splenic hydatid cyst. Went to surgery. That's what it looked like grossly. And here's pear aspiration. It's a procedure whereby we aspirate the contents of the cyst, inject a scolicidal agent to kill the actual parasite, such as alcohol or hypertonic saline, 20%, and then re-aspirate. And the idea of doing that is to avoid having an anaphylactic reaction in case of a spill, or in case of a spill, the entire abdomen could get daughter cysts, and the patient will be worse off than they started. So that's the hydatid liquid with hydatid sand, and this is the germinal layer that the cyst capsule that must be removed intact in totem that Dr. Sbeih described initially. Another case of a 37-year-old male from Saudi Arabia, this time presented with dyspnea. Chest x-ray showed something up here, right? And then CT scan showed an epicardial hydatid cyst. Described by echo as well. So it can involve any organ, really. And this was a very refined Iraqi gentleman, 64 years old. He's a professor of the English language at the university, brought in by his apprehensive wife. And he's like, I don't know what I'm doing here. She brought me here. So he had only stopped breathing 5 days before and collapsed in shock. Taken to the ER, admitted as a case of septic shock, administered antibiotics. 5 days later, the patient was discharged. They got a blood culture and told him to follow up with the blood culture result with infectious diseases. His wife was so apprehensive that because this has happened 2 times before, 10 years ago and 7 years prior to presentation. Suddenly the guy collapses to the ground, hypotensive, and in danger of dying. And so she carries the epinephrine pen with her so she can administer it to save his life. So he was carefree, but she was worried about what lurked underneath. Nothing remarkable about exam or labs, but his CT scan was certainly remarkable for this complex cyst with many daughter cysts in a rosette form, some calcification, indicating that it had begun to heal. But the problem, we think, is that it was still active. His echinococcal titers were high. And we think what had happened was a leak, an occasional leak from trauma or the like, causes mast cell degranulation. His IgE levels were high and anaphylactic shock. He underwent cystectomy, and we were asked, when can we start doing the cystectomy? And we gave a week of albendazole to try and sterilize the contents of the cyst, then went to surgery, and he did very well afterwards. And this is described in the literature. This is a paper from Turkey where anaphylaxis was due to a spontaneous rupture of this person's isolated splenic cyst, which even had this calcified crust in some areas. Infection control, there's no person-to-person transmission. But when you remove the cyst, please don't feed it to the dogs. Final case, 29-year-old mechanic presented with right upper quadrant pain, otherwise unremarkable pigmentation. And he had a complex cyst where you notice how there's rupture and a removal of the germinal layer away from the actual body layer of the liver. And this is called water lily sign. And you can tell how chronic this has been. It's so big that it caused probably some atrophy. There's not much liver left on the right lobe, and consequent compensatory hypertrophy of the left lobe all the way up to the spleen. It's never good to find free air in the abdomen, right? And this probably was due to rupture internal and externally, and communication with the biliary tree or the intestines, which is a complication that calls for surgery. So these cysts can rupture and cause biliary fistulae or compress vital organs. In cases where there are many daughter cysts, it is preferable to do surgery rather than to aspirate through Pear. Surgery may be open or laparoscopic. Larger size cysts, superficial cysts at risk of rupture, and extrahepatic cysts are indications for surgery. If the cyst is inactive or calcified, surgery is not needed, unless, just like I presented to you a minute ago, there's another reason for surgery, the anaphylactic reaction that nearly killed the university professor. The working group from WHO has classified the cyst ultrasonographically. There's a simple cyst, an active cyst with daughter cysts, and then a couple of transitional stages, and then when it's calcified, we believe it is inactive. And according to the classification, the advice for treatment follows accordingly. And I'll generally tell you that apart from surgery, medical therapy consists of benzidazoles, mebendazole, the older form, and albendazole, the newer, more standard of therapy nowadays. We typically give 3 cycles of 4 weeks on and 2 weeks off, and it's all oral, so people who are afraid of needles need not worry. Preferably given as adjunctive to surgery or Pear. Praziquantel, sometimes we go to that, Jamal, but not, there's no strong data. It's just a backup drug when we can't use albendazole. The albendazole works through inhibiting the microtubule assembly and killing the germinal cells of the parasite. It's fully absorbed. We advise to be given with fatty meals. We observe for side effects such as hepatotoxicity or cytopenia and alopecia. And typically 30% of the cyst will resolve, 30% to 50% will decrease in size, and there'll be no change in 20 to 40% ultrasonographically, by ultrasound. But it is supposed to kill the parasite. So I'll leave you with this anti-smoking Jordanian ad as my colleagues make it up to the podium. Thank you very much.
Thank you. May I ask Dr. Jamal, any comments about the Hydatid disease in general?
You're going to continue surgical or
What about comments on what we have already said?
يعني بس basically الدكتور منتصر حكى كله اللي هو WHO stages اول شيء والميديكال ثيرابي في some data يعني بس شو صغير to add some comments في some data على combinations زي ما حكى الدكتور منتصر to add praziquantel beltoside او nitazoxanide مع albendazole لكن never proved useful. Albendazole alone is enough. The second comment, we used in the past, about 20 years ago, more than 20 years ago, to give albendazole 1 month on, 1 month off, 1 month on for 3 cycles. It became, زي ما تصل حكى, 2 weeks off and then 1 month, يعني 1 month, 2 weeks. Now, في some data which I'm using to continuous 3 months, 90 days, حتى ما يصيرش dilution effect للدراج في السيست نفسه.
Even 6 months.
Yes, up to that يعني بس continuously you are treating the cyst for that. هذول من الاشياء. الشيء الاخير اللي في ستاديز اللي عملت بالجامعه الاردنيه كان في ميتنج مؤتمر بازيتولوجي، فعملت جود ريفيو على المنطقه. في عندك الباترنز اوف سيرجري، بنحكي عن ابدومينال والتشيست، اللي هو في عندنا الابدومينال مثلا في لابراتومي، في لابروسكوبيك سيرجري، وفي اللي حكى لنا دكتور منتصر البير اللي هو بانكشر اسبريت انجكتري اسبريت، اللي بعملها مع كريم الخالدي بالخالدي عده مرات، يعني سويناها في مرضى كثير بدهم فور سم ريزن. السنه هاي شفت حوالي فوق 30 40 حاله، مش عارف ليش، من عمان، كلهم ساكنين بعمان منتصر، يعني مش من برا كمان، يعني عمان وما حولها، غربة السوق وهذول. فالداتا بتحكي انه the best result better than open اللي هو اللابروسكوبي the recurrence rate and البير if it's done properly with 20% normal saline او absolute alcohol which destroys the daughter cyst، يعني بيكون better results even الريلابس بيكون اقل بكثير. بس لكم.
Yes, actually, I'm Dr. Sbeih, but we're a surgeon. The idea that nowadays what we are adopting, the Dr. said that we are adopting the continuous albendazole, not intermittent. The other thing that what we are using in PER, there are a lot of studies about what you should use at injection. The most effective material actually is cetramide. You know that there is the idea of just trying to use 20% saline. There are a lot of comparative studies. The most perfect one, the most we are just comparing the 20% saline, which is not available most of the time actually. What's available and cheap is the Sablo. Sablo, there is cetramide, chlorhexidine, and both are more effective than 20% saline. So we can use either Sablo, which have both cetramide and chlorhexidine, or one of those two materials, and they are very more effective than alcohol. And actually, for the last 30 years, I've used most of these. For example, we are using alcohol actually, but nowadays we are using only chlorhexidine or Sablo.
Okay, Professor. Who's coming?
اهلا فيكم. انا راح اتكلم عن الهيستوباثولوجي اوف هايداتيد ديزيز. حقيقه الهايداتيد ديزيز الهيستوباثولوجي has characteristic features. If you don't see them, you cannot call it hydatid. At least you have to see one of these three to call it hydatid disease. You know, because sometimes all the hydatid may not have all the features of hydatid disease. This is surgical specimens. هذه كانت from the liver, and all specimen حقيقة from the liver, showing very, you can see very thick capsule, and these are daughter cysts. But you can see how this calcified, and not many features of histopathology are seen. يعني يمكن واحدة من ثلاثة اللي راح أذكرهم. هذه لا, you can see السبيسمنت هذه مختلفة. It's a more fresh specimen, and الوول تاعها is thin. So you have two different stages, or two different chronicity features من hydatid. Young hydatid and really old calcified hydatid. يمكن دكتور سمير بيشوف الشغال هذا الليفر أكثر, يعني he can tell. But this one is really up to rupture easily in the patient, but this is difficult to rupture because the wall is very thick. Usually, because in the brain usually we don't form fibrous tissue, you expect to see very thin wall, but in other tissues you can see it big wall. هلا three features. One of these three you have to see to call it hydatid. The most common or the most important is scoliosis. Scoliosis you can see هذا نفس البارازايت. بدي اورجيكم this is different stain. انا راح اورجيكم عده stains حقيقه, will show different stains, will show how they differ from each other. This is a difficult stain. This is an actual case from my experience. I did fine needle aspiration and I aspirated these patients, and I recognized these are hydatid from the presence of one of these three features. The first feature is scoliosis. You can see هذا scoliosis بتطلع هون. You can see هون الهوكس تاعتهم, هون الاسنان تاعتهم. So this is the parasite, and these are the hooks, and you have to see sometimes the hooks. When this is a PS stain, and it stains the wall but does not stain the parasite itself. This is a solid look section from a fine needle aspiration that I did from the lung. A lung patient, a female, in their 30s, I aspirated the lung lesion, and you can see on this is part of the scoliosis, part of the parasite. So this is a more complete part of the parasite. So on another sections of different parts of the parasites, you can see them, how they look like. And you can see in here they look like the hooks اللي راح نورجيكم فيها in more detail. This is another section of the parasite. You can see it depends on which section you took when you section it. You have to recognize it because they have variable shapes. Again, هنا نفس different cases حقيقة. I have about 30 cases where I aspirated and proved by fine needle aspiration to be hydatid. Some of them in the lung, some of them in the liver, and some of them, I think one time Dr. Jamal Al-Wadi, he called me for a bone, disseminated echinococcus, multifocal. Yeah. I did it from the pelvis. You can see this is the parasite itself, the scoliosis, and again you can see the scoliosis here. This is another stain, حقيقة, this is Zell-Nelson stain. Very important طبعا for your infectious people or infectious doctors to see يعني حتى شو Zell-Nelson not only stains acid fast bacilli, it also stains other things. So when you are a pathologist and you want really to show things in different colors, it's nice to show them in different colors because you recognize them. If you don't use it يعني from out of your curiosity, sometimes probably you don't recognize it. This is Zell-Nelson stain, which you use it for acid fast bacilli, but it stains very well and nicely the scoliosis. And a difficult stain in different parts. Also, these are the scoliosis. This is the second one is the hooks. This is very, very important. يعني sometimes in the fresh one you see hooks more than parasites. These are the hooks. See, this is a BAB stain. This is a VS stain, different, and this is Zell-Nelson stain. And you can see them in different stains. هذول الهوكس حقيقة these are the ones that are present in the ostium بتاعت البارازايت وملصقين فيها. They are really anchored to the parasite body, and we call them hooks because they are hooked on the and it's really very interesting to see the typical shape of them. يمكن هذول بذكروني انا لما اطلع عليهم بفتحات البيبسي القديم بتاعت ما ايام ما كان البيبسي ناس يشربوه بزجاجات يعني. This is called the hooks. And if you see one of them, usually don't see many of them حقيقة. If you see one of them, and in some cases I only saw one in all the slides, and you can call it echinococcus. But the third one is the laminated body. And Dr. Ibrahim show where is the laminated body. Laminated body is the least specific لأنه ممكن other things may produce something mimicking it. You can see how the different layers of fibers, and you can see this is BS stain. It stains with BS stain as I showed you earlier, and this is H&E stain. So this, if you see one of these three, you can call this as a hydatid cyst for confident. If you don't see them, you cannot call it. Thank you.
As you see, pathologists always refer to food articles. So he referred to Pepsi. They say about cauliflower, flowers, etc. So let's see what are the organs involved in hydatid disease. You may get one system, you may get multiple organs. Liver is the main thing, as you can see. Different sizes, look at this. Could be calcified. It can affect the lungs. And Dr. Muntasir showed the case of cardiac hydatid, can affect the kidneys. And this is very interesting. Renal hydatid presenting with hydaturia. Patient was passing these cysts. Or this retrovascular hydatid cyst causing left kidney atrophy. Can affect the bones. On this paper from Iran, where it is also endemic. I think the experts in the world about hydatid are the Iranians.
Turkish.
Actually, the Iranians are more than the Turkish. Bones like this, see? Now, what applies to the bones and the liver in terms of the pair, i.e. aspiration of the cyst, does not apply in the brain. So there's totally different management of hydatid disease of the brain and hydatid disease anywhere else. Can affect the spine. Again, this is from India. This is from Turkey. Affecting the spine. Look at this. Could be, mostly it is extradural, because it's affecting the bone, but it can be intradural, extradural. Here this is strongly sacrum. It can affect the soft tissues. And this is a paper from Italy. Again, we are talking about Mediterranean area. Italy, Greece, Turkey, the Arab world, it's endemic. Soft tissue, hydatid. Let's see what happens to the head and neck. Can affect the orbit. Can affect the skull and the orbit like this. Again, paper from Iran. This intraosseous cyst inside the bone. This is extradural cyst, extradural. This is a calcified extradural. It can be extradural like this one, extradural. You may not think that this is extradural, but it is. And it can affect extradurally anywhere, including the skull base, like this one. Paper from India, subdural, like that, subdural. Primary cerebral means that the brain is the only organ affected. No other organs are affected. This is very, very rare, like in our case. Actually, our case is liver and brain. I have about 4 cases where only the brain was affected. This is from Tunisia, again a primary, affecting the brain only. Another paper from India, Asian Journal. Or it can affect multiple organs, brain and liver and so on. This is a very nice paper. It is by Dr. Hydatid and his son George. Both are friends of mine and I'm proud to know them. Late Dr. Hydatid was one of very few neurosurgeons in the Middle East. One was from Pakistan, one was from Iran, and one was from Lebanon, Hydatid. Then followed by Dr. Sbeih in Jordan. Your hydatid cyst can get infected. So secondary bacterial infection. This paper from Libya and Egypt. And this same paper about infected. Look at the appearance. You may think it's a tumor. It is just infected hydatid. Or we can get multiple intracranial cysts, like this. Can affect the sterofossa, which is a rare site. Again from India, this very unusual multi-loculated cyst in the sterofossa. From Syria, this paper about this giant in the posterior fossa. Anybody may think this is arachnoid. And the other day, one of my colleagues were asking if I think this is arachnoid, I will open it. My answer is, whenever you see a cyst, deal with it as if it is hydatid until proven otherwise. Don't puncture it unless you are sure. So these are in the cerebellum. It can get calcified like this. So the ordinary teaching that hydatid cyst without calcification and without edema, without things like this, it can get some calcification, like this case. Look at this. You may think this is an abscess. This was a calcified hydatid cyst proven by histology from Turkey. Another primary calcified. Can be inside the ventricle. Hydatid inside the ventricle. Again, you may think of it as arachnoid or another type of cysts. This is a precautionary word to our residents. Do not open any cyst unless you are sure it is not. All the measurements, took all the precautions. From Pakistan, again, this giant cyst. So you can have a single cyst with multiloculation inside, with daughter cysts, like this. Multiple cysts. So single cyst or multiple, and the single cyst could be single loculus or multiloculus, like this one, multiloculated. Again, multiloculated cyst. Again, here you may think of astrocytoma. Unusual signs like this in the midline or inside the lateral ventricle. Contrast, they can take contrast. Don't be fooled. This one is taking contrast. So taking contrast does not mean this is not hydatid. Having calcification does not mean this is not hydatid. You can see the hydatid sand inside very nicely. From the Tunisia, this case with lots of edema. Again, the classical teaching that hydatid does not entice any edema, it does in these cases. So what's the treatment? Surgery is the main thing. And in the brain, we do not believe in aspiration at all. You should not put a needle into that cyst at all. You should take it completely out. And this is following this man, surgeon, Ed Dowling Jr., who invented this hydrostatic expulsion. I will explain it. You would have put the patient so that the cyst would fall down, or that goes up. You have to have a large flap. You have to have a good cortical opening in the brain. Dissect in the right plane. As you said, you have 3 layers of the cyst, so you have to dissect between them in a proper fashion, and then use the Valsalva maneuver, and you take it out without rupturing it. If it ruptures, patient either dies on table or he will have a major recurrence and he will die later. Brain hydatid is very serious. So how the cyst would rupture? You have seen a case like Dr. Muntasir presented, this Iraqi gentleman, Iraqi professor, who would develop hypotension and falls down because there is a spontaneous leak from the cyst. But as you are doing surgery, of course it could be traumatic, as you are doing surgery, you may yourself rupture it. And this can lead to anaphylactic shock, collapse, cardiac arrest, and death. This is the seriousness of hydatid. We do not use in the brain this pair technique. Pair, you puncture it, aspirate, inject hypertonic saline or citramide or whatever, and then you resect it. What are the complications of removing a brain cyst? You may have subdural effusion, you may get hydrocephalus, you may get polycephalic cyst, you may get epilepsy. Examples of postoperative: subdural effusion, you may get hemorrhage at the site of the cyst, you may get polycephalic cyst. The recurrence, up to 30%. So cyst recurrence is as dangerous as the cyst itself. And usually it takes 1 year for it to recur back. This paper is very famous in the as a landmark paper from Turkey, from Akimus in Turkey, published in Journal of Neurosurgery in the year 2000. About 330 patients who had cranial hydatid in Turkey alone. They could excise 207, ruptured 26% ruptured. This is a very experienced surgeon with his colleagues, with the recurrence of 17% and mortality of 10%. Hydatid disease of the brain is very, very serious. So let's go now to our case presentation. We're almost half time. As I said, primary hydatid cyst, i.e. brain cyst without any other organ involved, is very rare. It's almost 2% of all echinococcus infections. This is an Iraqi boy, 7-year-old. That goes back to November 2004. I had many cases of brain hydatid, but this one is very illustrative. He came with 1 month history of right-sided weakness, right facial weakness with slurred speech. He then developed left eye ptosis and left eye squint. In his examination, he was a little bit feverish. The last tone scale was 15/15. He had right facial, he had left third nerve palsy and left second nerve palsy. That's why he had the squint. He had weakness in his upper limb, 4/5. Same thing in his lower limb, and his plantar response, the Bensky sign was positive. His 1 PCs were normal. You would expect with parasites infection that you may get some xenophilia, but this was okay, no change whatsoever. His xenophilias were normal. Liver functions were okay, although we know that he had liver Hydatid cyst. So these are the images. Is Dr. Khandaqji here? Maybe?
Yes.
Please, can you comment on this? This is your case. You may not remember it, but basically we want to hear from you about the ultrasound in Hydatid disease.
And I did do ultrasound at that time when I forgot.
Yes.
بس هلا بدي احكي بشكل عام لان الناس
Yes, yes, of course.
Good evening everybody. Really I forgot this case that I did ultrasound for this child, but as we can see we have a completely cystic, well-defined, well-demarcated lesion. It is of thick wall surrounded and definitely compressing the adjacent structures. It is homogeneous, no daughter cysts within it, and no signs of, let's say, complication, hemorrhage or infection or anything else. It's completely cystic or hypoechoic. Thank you.
And you also did, Ayman, chest X-ray and abdominal ultrasound, as you said, and you did abdominal CT scan with the same findings. This one large Hydatid cyst. So this is liver and brain involvement. Okay. Chest X-ray normal, this is normal. Dr. Atamna, would you like to comment on the radiology of
مساء الخير. أنا دكتور عماد عتامي, consultant radiologist. We are dealing today with the Hydatid cyst multilocularis, granulosa, I mean. The typical appearance of this cyst is well-defined, imperceptible wall, no edema, and it does not enhance, and the calcification is very rare, less than 1%. And it appears, this is T1 weighted post-contrast. We can see the cyst is, this is CT scan upper, that CT scan. This is this is cystic lesion here, and CT scan also, this is hypodense lesion causing mass effect into the lateral ventricle, shift midline structure, obstructive in the right lateral ventricle. Same finding. This is MRI. The most important thing is MRI. You can see this is T1 weighted is hypo-intense, T2 weighted is hyper-intense, imperceptible wall does not enhance, and this is diffusion. There is no restrictive diffusion, which is very important to differentiate this from abscess. The content of this cyst follows the CSF intensity, but in this case, you can see this is a clear sequence, should be suppressed, but does not suppress, which means there is a sand and some turbid fluid. And this is, I think, this is ADC map, this is bright. This is large cyst, also the same, it can compress the left lateral ventricle, shifting midline structure, causing some hypercare. Black into 1, bright into 2, and this is ADC map. Post contrast, there is no enhancement.
So this is our patient.
Yeah, this is our patient. I think just we have T1 weighted, P and post contrast. You can see this is a huge mass, cystic mass lesion, which appears hypo-intense in T1 weighted, compressing the left lateral ventricle and causing compression at the level of foramen bone row, causing a hydrocephalus, right-sided lateral ventricle. Post-contrast, there is no any enhancement of this cyst. The same findings, post-contrast, no evidence of enhancement and no evidence of edema. Post-contrast, I think this is post-contrast, or at least post-contrast, there is no any evidence of any enhancement. This is such, I think this is coronal, the same finding, this is pre-contrast, this is post-contrast, no difference. Pre-contrast, post-contrast, coronal view, there is no evidence of any enhancement. This is sagittal view, there is no evidence of enhancement. T1 method, post-contrast, pre-contrast, the same findings. We don't have T2 weighted, which should be and bright T2 weighted and suppressed in first sequence.
Dr. Ayman, this line اللي بالنص is artifact or real?
This one?
In the middle.
This?
In the middle picture. Yeah, there's a line, shadow. Is this a real?
This is artifact. This artifact. Our differential.
All pictures.
This line?
Yeah, present also there.
Vascular marking.
No, it's an artifact.
You can see it also here. You can see it here.
This is an artifact. You can look for here. An artifact. Our main differential diagnosis, we have 4 differential diagnoses. The most important one is brain abscess. Brain abscess can do restrictive pattern in DWI. Second, it has a thick wall and enhanced. Third sign is edema. Second differential diagnosis from primary cystic tumor and primary or metastasis. Primary brain tumor or cystic brain tumor has an nodule and thick wall can be enhanced. Also, it has an edema, which is not in our case. The cystic metastasis has a disproportionate edema because the metastatic cyst is foreign for the brain, while they actually become more in comparison with the glial cells. The third thing is hydatid cyst as arachnoid cyst. It looks like a hydatid cyst, but the only way to differentiate is to do spectroscopy. Spectroscopy in hydatid cyst, it can reveal amino acid اللي هم اسيتيت وساكسينيت وارينين in pp 1.4 حتى 2.5, but it's not the case of arachnoid cyst. The last one is the polycythemia cyst, which is traumatic, and we have gliosis and encephalomalacia.
You wanted to say something?
هيثم عزام خريج إيران هو هذا السيست له قصة معنا وله قصص ما كانش يمر علينا يومين بدون ما نشوف هذا السيست، سواء كان في يعني شفنا في كل المناطق في الجسم من CNS. Okay. I'm Dr. Hytham Azzam. I spent 25 years in Iran. I studied there, I specialized there, and I worked in the Shiraz University as a professor or attending. So in Iran, it is Hydatid disease is very common. And we saw a lot of cases in everywhere of the body, bones, lungs, liver, soft tissue, in everywhere of soft tissue. And we had several articles we produced in the university, and some of these articles was reference articles. But I want to say that if the surgeons, if they remember, or if we had Dr. Saidi, and he was one of the major world surgeons in Hydatid disease, and he had a cup, which is till now it's called Saidi cup. So he was, it was a cup from two pieces. He was putting the cup around the Hydatid cyst, and then he was cutting the Hydatid cyst from down. So it was known as Saidi cup. We had reference also in the appearance of Hydatid disease, the ultrasound, which Dr. Ayman talked about it. We can see the double wall sign in Hydatid cyst. It is an ultrasound. It was for the first time from Shiraz University Medical School. It was written as an article. The thing which I want to mention that once I was a resident, I examined, there was a mass in the chin here. When I examined, there was daughter cyst. So any cyst we see, first choice was Hydatid cyst in Iran. So I told my attending that we have Hydatid cyst in the chin. And because it was very, very interesting, I put the transducer, then I saw the daughter cysts were moving. I spent about 15 or 20 minutes. Then there was change in the location of the daughter cyst. I told the doctor who was the chief of the department. So he said, it is very interesting. Okay, you keep your transducer on one point and press the cyst. So I did. I spent about 1 hour and a half in the same location. So it was very interesting that all the daughter cysts came to the site of pressure. So he wrote an article that the daughter cyst, which was known as productive job, he said that he wrote that it is a defense job also, because when there is pressure or if the cyst feels the danger, all the daughter cysts will collect together to defend the Hydatid cyst. This was my talk about Hydatid cyst. Thank you.
Dr. Haytham, did you ever see hyper anaphylactic reaction secondary to Hydatid cyst?
Yes, yes, of course. We had a lot of cases. A lot of patients were died at that time from Hydatid cyst or metastasis from Hydatid cyst, means dissemination of the Hydatid cyst in the other organs or in the abdomen.
You mean spontaneous rupture and metastasis? Because we don't have metastatic cyst.
No, I mean metastasis means dissemination. I mean when it ruptures, then the scoliosis will spread everywhere, and then we call it metastasis as not a tumor.
But this is not anaphylactic. I mean anaphylactic shock. Do you see?
We had anaphylactic shock from we had septicemia by Hydatid cyst.
I mean anaphylactic shock like this.
Yes, we have.
Because I think this is overwritten in the overestimated in the literature.
No, it is rare, but we have seen. Thank you.
Now, differential diagnosis. I opted to give you this paper by Anne Osborne. Anne Osborne is she is actually the most famous neurologist, and she wrote this paper about the challenge of diagnosing cysts in the brain. And the intracranial cyst, an imagery diagnostic challenge. It is a diagnostic challenge. Let's go and see. This is early Hydatid cyst. You may not diagnose it. These are still in the early stage. They could be multiple.
Like a cysticercosis.
Yes, arachnoid cysts. You don't need always the Hydatid cyst to be rounded and beautiful. Sometimes they are distorted. So they can look like arachnoid cysts. We have ways of differentiating, but arachnoid is one of the challenges. For encephalic cyst, trauma, head injury, post-surgery, you'll find a cavity. Subcortical cyst, leukodystrophy, it looks like hydatid. Epidermoid cysts, again, there are ways of differentiating, but you have always to be careful. Dermoid cysts, they could be in the cellular supracellular area. Choroid fissure cysts, choroid fissure. Ependymal cysts, this is the ependymal cyst and this is the choroid plexus. Neurocystic psychosis, looks very much like our case, the early cases of Hydatid. Choroid fissure cyst, as we mentioned. Choroid plexus cyst, from the choroid plexus itself. You can get calcification, you can get cyst, which is a form of degeneration. Parenchymal cyst or neuroglial cysts. Look at this. Neuroglial cyst. Looks very much like Hydatid. And this is one case of mine, an Iraqi gentleman with this lesion. When I went in, I was careful, I prepared myself. Maybe this is Hydatid. It turned out to be an intelligent cyst. And this has been histologically proven. Abscess. But again, it looks like a calcified Hydatid. So be careful. Enlarged perivascular spaces. This is one of the forgotten items that sometimes the perivascular spaces can get bigger and they show like this. You may think I'm exaggerating. This is a paper. Cerebral and lower echinocorpus mimicking primary brain tuning. Would you ever think that this is Hydatid? Would you ever think that this is Hydatid? So they can look like tumors. Again, another paper. Echinocorpus presenting as a giant anterior cranial basilar tumor. Easily you can miss this as a tumor. And hence again, common is common, rubbish. You have to know the least commons so that you will think nicely. You have to know the list. Of course, you will follow the first and the second, but you have to think to the end of the list. These are collection of tumors that came across my way. Again, this is hemangioblasoma. There is no nodule inside, just the wall. Very tiny nodule, of course, we found. Parasitic astrocytoma. You may not get the nodule. Mets. Would you imagine that this is metastasis in the brainstem? And this is one of the fantasies. Hydatid cyst in the pineal region mimicking pineal cyst. This came from Saudi Arabia. So these are not fantasies, these are real cases, and you will face them. If you are well prepared, you will deal mass with the patient. If you are ill prepared, like most of us, then you will not be able to manage this case properly. We did a few consultations with this patient. Dr. Fahad, are you around?
Yes.
Can you come over, please? We have Dr. Fahad Soudi, the general surgeon, to see this patient because of the liver disease that he had.
Actually, I remember this patient for Dr. Ibrahim consulted us for this child. The child has two concomitant diseases, one in the brain and one which is pathological and symptomatic, and the other one was asymptomatic, which was accident discovered during the workup. Which was discovered during the workup for the patient. As long as the patient is having one pathological and symptomatic lesion in the brain and another asymptomatic or silent lesion in the liver, so the priority was the decision to go for the brain surgery first and to get rid of the brain pathology, and then after the patient gets rid of the things and he gets recovered, having a course of albendazole, and then later on to go for the liver disease.
This is your writing, so that if you change your mind.
Yes.
The anesthetiist at that time was Dr. Jabal Sharif, who will address this soon. He announced the patient fit for general anesthesia. But I'd like Dr. Professor Aisha to comment on what are the challenges of anesthetizing such a patient with the hydatid disease.
Good evening, ladies and gentlemen. My name is Dr. Firas. I'm an anesthetist working at Farah General. I'll be talking in general. In every case in anesthesia, we have general principles for anesthetizing any patient, and we have specific considerations. For example, this patient is a child coming for intracranial surgery. So we have general principles for anesthetizing pediatric patients who are presenting for neurosurgery. And for this specific case, I'm going to be talking very briefly about what are the concerns regarding patients who are presenting for suspected cerebral hydatid cyst, which is very rare and usually seen in children, which are more common than adults. This could be explained by the presence of the right to left shunts, such as patent ductus arteriosus. This is one of the theories how the granulosis has spread to the brain. So it's very important in these patients, as we will see later, to ask for an echocardiography. So the gold standard for the treatment is surgical removal. And specific considerations, so it should be kept in mind that extracranial cysts may also be present in these patients, such as we've seen in this case. In this case, the patient had a liver hydatid cyst. So most commonly, it's very rare to have an isolated cerebral hydatid cyst without having other organs involved. This has very important implications as anesthetists, that in case not enough radiological examinations have not been done, we should ask for it. So thorough radiological evaluation of the patient is necessary with chest x-rays, abdominal ultrasound, or CT scans. Echocardiography is of utmost importance, especially in pediatric patients, just to see how these cysts have occurred in the brain, because most of these patients, especially in pediatric patients, have either patent ductus arteriosus or ASD. So in order to prevent the recurrence and anaphylactic reaction, the cyst should be removed without rupturing it, as Dr. Ibrahim has stressed. So the aim for anesthesia in these cases, especially for cerebral hydatid cysts, to provide relaxation of the brain tissue during the excision of the cyst, and establishing a clean surgical field, and necessary precautions against possible anaphylactic reactions, which is the most scary part of the surgery. Because mortality rate due to anaphylactic shocks ranges between 3 to 6%. But I must stress that these patients, for their families and loved ones, are 100%. The incidence of intraoperative anaphylaxis due to hydatid cyst is reported as between 0.2 and 3.3%. And I must stress here that it's mandatory to have invasive monitoring, especially arterial line. Because even though it's 3.3%, I must stress that these patients, again, for their loved ones, it's 100%. So if anaphylaxis develops, all medications and the operation should be stopped, so the surgeon should be informed immediately. The surgery has to be stopped, 100% oxygen should be started, and the use of adrenaline for vasopressor treatment is the first line of treatment. And I cannot stress enough, in case of anaphylaxis, adrenaline equals life. With no adrenaline, there is no life in case of anaphylaxis. All other measures are secondary, especially cortisones, antihistamines, all these other measures, or even fluids. These are secondary measures. So, in case of anaphylaxis, adrenaline equals life. One of the most important points that I have to stress for our colleagues, whether it's being anesthetists or surgeons alike, in case of using hypertonic salines, in case of irradiation of these hydatid cysts, especially in pediatric patients, we suffer a very major complication, which is hypernatremia. Because it might cause cerebral edema, coagulation dysfunction, electrolyte disturbance, and acid-base imbalance, and even there is reported cases of fatality after applying even 20% hypertonic saline. Thank you very much.
هل تصب الأدرينالين على المنطقة التي حدثت
It's IV injection and should be diluted.
Do you give them pre-operative cortisone?
There are reported cases of treating patients preoperatively with antihistamines, and it has proven to help preoperatively. But usually, the surgeons in case of cerebral edema, they are usually, especially working with Dr. Ibrahim Sbeih, usually these patients are always on corticosteroids.
Okay, let's go for surgery. Remind you, this is microscopic surgery, and we have a challenge here. This cyst measures 11 by 10 by 9 centimeters. It's occupying most of the brain. And you have the challenge of delivering it without rupturing it. So let's see. I'm just here putting my hand with an orange to compare it with the actual size of the lesion. Again, very vital important step is to be in the right plane to differentiate the cyst from the surrounding brain. We'll see it on the video. So I position the patient so that when I deliver the cyst, it will fall down. So I position the patient this way so that when I manage, it will fall down. I give it a gravity effect. Here I'm separating the dura of the brain, and you can see the lining of the cyst. You have to do microscopic. You just cannot. Neurosurgery is microscopic. If you ever see a neurosurgeon not using the microscope, he belongs to the dark ages of neurosurgery. It's no more naked eye surgery. No more. Even if you are doing a disc surgery, it's microscopic.
Did you open the skull more than usual?
Of course. As we said, it has to be generous because I want to deliver a huge baby from this very narrow passage. It's actually delivering a baby through very narrow vagina or very narrow uterus. But look at this. You can see through. This is the most dangerous step of the surgery, to take the dura off the cyst. And you can only do that under the microscope. Microscope gives you 12 to 15 times magnification, and of course the coloration. So this is the dura being reflected. Now I'm trying to find a good plane of the cleavage between the outer layer, which is belong to the brain, the glioses, and the laminated layer of the cyst. I don't want to go to the granular layer of the cyst because it will rupture. It is so thin. Even with the laminated membrane being there, you can see the scolices, the white stuff. These are daughter cysts. And I want to show you. Here I'm doing this Downing technique, which is hydrostatic pressure. Having found a plane of cleavage, you inject saline so that the cyst will deliver itself. Every 1 cc of this cyst contains 100 million of worm. Every single cc. So this is the hydrostatic pressure. You push in the right plane. If you don't push in the good plane, it will rupture. Now you feel your heart is going to stop when you are doing this. You will get palpitations and atrial flutter and fibrillation. And here it is, it's going. This is the cavity inside, and you can see the ventricle lining. So this cyst was extra ventricular, it was not interventricular. So what you do with this huge cavity, one of my mentors taught me this trick, is to put a Foley's catheter and inflate it with saline or gas so that it will take the cortex up. You keep it for 2-3 days and then you take it out. Maurice Chucks is the name of the man who gave me this trick. And this is the cyst. And again, we'll put a measure so that we believe that this is 11 by 10 by 9 centimeters. It is so thin. So we don't use the pear thing that we use in the liver. Again, here I'm putting my hand with an orange so that you will compare both. You can see through, so thin. This is the child. His father and mother took the permission to put their pictures. Long time ago, he's back to normal. His weakness disappeared. His squint disappeared. It's so satisfactory. Satisfaction for a job that you do. Well, this equals the word, this case. This is what's natural. So post-operative coach, patient woke up immediately. We don't allow patients to go on a ventilator. This is a bad practice that I'm fighting all my life. This explanation that some of the consultants give to the residents, let us put the patient on a ventilator عشان نريحه. This is nonsense. There's nothing in medicine or surgery like this. Patient, if he's well, he should be awake on table. Don't send patients on ventilators because you are afraid that people would know the truth about what you have done. This is post-operative, this is before surgery and after surgery. Again, look at the midline shifted, went back. So, he was moved from the ICU to the ward and we discharged him on the 11th post-operative day. And as Dr. Fasuri mentioned that he was medically treated with the benzodiazepine, and he was discharged, came back 1 month later, where Dr. Fahad did the excision of his right liver cyst, and he went back to Ibrahim. So how can we prevent Hydatid disease? I'm going to touch on very sensitive issues here, and I hope you understand my concern. Bismillah ar-Rahman ar-Rahim. In Quran, Surah Al-Saffat, فلما بلغ معه السعي قال يا بني إني أرى في المنام أني أذبحك فانظر ماذا ترى قال يا أبتي افعل ما تؤمر ستجدني إن شاء الله من الصابرين. سيدنا إبراهيم وهو يريد أن يضحي بابنه لأنه أجعل وحي أن يضحي بابنك فأمر من الله أنه يوافق. I put it in English so that our international audience can see the words in Quran. Because it is mentioned like this.
Genesis.
Yes. Now, this is in Genesis. When they reached the place God had told him about, Abraham built an altar there and arranged the wood on it. He bound his son, Ishaq, and laid him on the altar on top of the wood. Then he reached out his hand and took the knife to slay his son. But the angel of the Lord called out to him from heaven, Abraham, Abraham. Here I am, he replied. Do not lay a hand on the boy. He said, do not do anything to him. Now I know that you fear God, because you have not withheld from me your son, your only son. Abraham looked up, and there in the thickest he saw a ram, caught by its horns. He went over and took the ram and sacrificed it as a burnt offering instead of his son. So this is in all religion. Abraham wanted to slay his son because he wanted to follow the order of God.
But son Ismail مش إسحاق يعني.
I'm mentioning it as in Genesis.
اسمع شوي بس بغيت اسمع شوي صغير.
Sure.
الرواية اليهودية لنفس القصة انه سيدنا ابراهيم بيذبح اسحاق وبالضبط فوق الصخرة اللي قلنا على صخرة المسلمين. الرواية الإسلامية إسماعيل عليه السلام في الكعبة. إذا لاحظتوا في جملة هون بيكتبوا his son and the only son. ما بيعترفش بإسماعيل الصن.
نعم.
لأن الحكامات اليهود تحكي معهم بقول لك he's a bastard ابن حرام. That's their belief. إحنا كمسلمين بيختلفوا عنهم فخلص.
We have an international audience, so we'll put all the opinions together. But this is the painting that Abraham is trying to slay his son, and he's prevented by the angel. Why did I put this? Because we are coming to the Eid al-Adha, Eid of sacrifice. This is a major problem in the Arab world, in Jordan and in the Middle East, and we have to face it. We have to stand up for it. We should not fear any comment from any religious person. Sacrifice is part of our religion. We respect it. It's very nice. You sacrifice so that you would spread the meat and the food for poor people. It's very nice. It's imitating Abraham. But to get in touch with the shepherds like this and the dogs. That's the main concern. So livestock is slaughtered without veterinary supervision. And the other board, there's no supervision from the government. I'm sorry to say that.
بيكونوا معطلين ما هم
I come to it. You will notice that male children and others are more because you will not send a female for this job. So usually male children and others are always the stray dogs in our streets, in our villages. Lots of farms, lots of livestock, and sanitary regulation during the Muslim festival of sacrifice. Sacrifice is good, but do it nicely, do it properly. Would you like this image? This is very, very backward. This is not good. This is very bad. Sacrifice is good, but to do it in the street like this is very bad. And when you mention, some talks would say, oh, you are against Islam. I'm not. I'm against the bad traditions that people do, which is not in the spirit of Islam.
هل هذه الصورة من عمان؟
Yes, absolutely. These are pictures from Egypt. I brought different pictures. This is from Amman. Look at this. Children and young adults are touching these livestock. People with their normal clothes. And this is my concern. Mayor of Amman is looking for the sites where these slaughters are. I mean, this is not nice. When you say the mayor of Amman is doing this, you are actually putting a legal stamp on it. It should not. The slaughter should be done in the slaughterhouse, not in the streets at all. So it should be done in the slaughterhouse, not in the streets, nowhere in the streets. And I thank you for listening. Any questions, any comments from anybody? Spoken? Please.
We had a case of intracranial Hydatid cyst at the age of 9 months. I don't know if you have, at that time, this patient was the smallest patient which involved by Hydatid cyst. I don't know if you have less than that age.
The youngest was 3 years old. But it can happen even in YouTube.
Yes, from Dr. Samir Ismaili, I don't know, at those days we were and the doctors were injected and treated the Hydatid cyst by injection of silver nitrate and sometimes alcohol. And later on we tried in radiology department to inject contrast within the into the cyst. I don't know if these are a valuable method of treatment or not.
Actually, I will tell you something. The most effective type of treatment for surgical treatment for the Hydatid cyst is not the way what we are doing right now. The most effective is what's known as pericystectomy. That means you have to remove all the 3 layers with part of the liver, and this will give you the chance to regenerate, and even you will not see the place of the cyst. This is the most important thing, that most of the surgeons, actually they will do the usual aspiration and just removing the germinal layer, and this is wrong. I think it's not wrong because sometimes you are obligated to do this. But if you want to do it properly, you have to do pericystectomy or liver resection according to that. If it's huge pericystectomy, if it's just in one loop, you can't do some kind of a liver resection. Now, the problem is that most of the cases, if you are doing just the ordinary, they will recollect seroma, and this is a problem for recurrence. You will not just differentiate between the recurrence and this, of course, the seroma. So if you want to do proper surgery, pericystectomy are not what we are doing right now.
يعني immediately dominated by surgeons as schooling thing to surgery. إذا حصل دكتور منتصر in his
Just
talk.
let me answer this. This is meant for international neurosurgical audience.
Thank you. As if you notice, Dr. Muntasir in his talk, he mentioned about the medical treatment with albendazole. And there's a point you have to, all of us will have to pay attention to, is that the failure rate in medical therapy about 30%. success rate is 70%, which is awfully high. Now, within this success rate, 70%, we subdivide them into 30 and 40. 40 they respond, and the cyst will shrink and dissolve, and 30 they will respond, and the cyst will stay the same. And if you cut through it later on by surgery, it's nothing but a solid mass. So medical therapy, honestly, in excluding the spine and the brain, in other parenchyma is useful and helpful, especially in multiple cysts. في second كمان point بالمedical therapy or non-surgical therapy, radiation therapy, which proved not useful at all. يعني عمل دراسات radiation it was excluded right at the beginning. فضل عندنا فقط البندازول وبندازول مرة ثانية for medical therapy, maybe bendazole number 1.
So no radiotherapy.
So what we are doing,
No radiotherapy at all.
what we are doing now, because you know that we have in the center we have a lot of those cases. That what we are doing, we are starting with patient with medical therapy first of all. But this, of course, private sector, you know that you have to do surgery in 2 days. No, what we are doing now, because we have 6 months appointment, so we are starting with the medical therapy and see what will happen. After that, we will go for surgery or not.
If you don't mind, I don't know whether my colleague as well, he can observe that. This year, I alerted Ministry of Health. I had in my office, in my clinic, so many cases. And when I asked them, where are you living? They said, within Amman and around Amman, not in suburb or villages outside. Just that.
What's your explanation?
So Junaid,
Just want to ask our infectious disease colleagues, how sensitive is, it's addressed to you guys, the infectious disease guys. How sensitive and specific serology is in such cases?
In a patient with a cystic mass, they're very sensitive. So in the right patient where you have that cystic mass, they're very sensitive and specific. Problem is when you follow them later and they still come back to you with 1200 or 680, it puts you in a dilemma whether to treat again or not.
so what's the normal title?
So it should be negative, really.
0.
Now, I mean, I know if it's positive, that's very helpful, but if it's negative, it may not be that helpful. Dr. Ibrahim, do you do serology on these cases before you operate?
Absolutely.
No.
My question is, sorry, I missed the first few minutes of the lecture. As I understood, the patient had.
Dr. Ayman Danat,
I'm Ayman Danat, I'm a consultant pulmonologist, although I'm a retinal surgeon. But
and he's
I have some interest in neuropulmonology. Thank you, Ibrahim. Thank you for this nice presentation. My comment, in fact, the patient had 6th and 3rd cranial nerve palsy and facial on the left side, I suppose. Now, I can understand why the 6th going from the bones going up again, the petrous bone, it will be compressed. But I'm just asking why the 3rd, going from the midbrain to the interventricular space, then under the tentorium, the lateral side of the pituitary gland, then the cavernous sinus to the sphere of the fissure to the eye. So which part of this 3rd was compressed?
It is because as it comes from the interventricular system to the roof of the 3rd ventricle.
So it's almost in the first 1/3 of its
First
origin.
part.
Yeah, first part, interventricular space.
True.
Thank you very much.
Sure, sir.
دكتور إبراهيم، مع الأعداد من التشخيص التفريقي الذي أريتناه، ما الذي يجعلك أكثر إحساسا بأن الموضوع سيكون cyst؟ هل أنت تحضر نفسك دائما لذلك أم أن هنالك إشارة توحي إليك بأنه هو الأقرب للتشخيص؟
The question was about the differential diagnosis of a cyst. Would I prepare myself for any cyst? The answer is yes. But before I go in, and this is the important issue, I have in my mind the list of the differential diagnoses. And I try to eliminate, if I have, as we mentioned, 30 differential diagnoses, I try to minimize them to 3 or 4. The size, the shape, the limb enhancement, the calcification, so many points to differentiate. But if I'm still in that, then I make myself ready, as this is a hydatid cyst. I don't puncture it, I go around it to find a plane of cleavage, and then I proceed.
And if it's rupture, what do you do?
Question very good. This, you go to the pair thing that the people do in the other sides of the body. So it's punctured, already punctured, so you put your sucker in, aspirate as much as possible, throw the sucker away because now it is infected, inject hypertonic saline in it, and then take the whole capsule out. But this is a definite recipe for recurrence.
You said that the recurrence was 10%.
And
all
that,
the
in that series, in that
yes,
series.
all the recurrence occur when the cyst is ruptured, or it could occur when you completely excise the cyst.
If you remove it without rupture, the recurrence rate is 0.
Sure.
So there must be micro ruptures, unseen ruptures.
Unseen ruptures, slight seepage of fluid. Any other questions? Yes, please.
If you remove a hydatid cyst in somebody, does he become immune not to have another hydatid cyst?
No.
Just one word. No. It does not provide immunity.
It doesn't.
Please, you said that the medical treatment alone carries the successful rate of around 70%. Yes? Medical treatment alone.
You said.
Yeah.
Jamal.
No, yes.
كنت ملهي بحي أيمن عمال.
If you, sometimes we have an area like skull base where the excision of the cyst is very difficult, or sometimes it adherents, hypothalamus, pituitary, optic nerve. Now, after medical treatment, I think you said, Dr. Muntasir, after medical treatment, even if the cyst size will not shrink, but it's now not effective anymore, yeah?
Yes.
So, in this difficult area, if we treat the patients by albendazole, then when we enter, rather than excision of the cyst, we do an aspiration. What do you think about that?
I have just with Dr. Saeed Fayoumi, chest surgeon, experience with this chest. And we gave a young girl, she has 3 cysts in her lungs, medical therapy, and the cyst size did not change, the same size. Of course, we have no way of knowing or telling that it's dead or alive. So I asked Dr. Saeed Fayoumi to do surgery for her. Let me just, he opened the lungs and he got the cyst, to answer your question, to the cyst, they were dead and the fluid was hard gelatinous material. So it's difficult to aspirate it. That's my...
After medical treatment?
Yes, it's difficult, very difficult. If it's respond, it becomes very hard, gelatinous.
So
you need a wide bore needle to just suck it out, which is difficult.
The title reflect if it's response or not. The title.
Titer زي ما حكى الدكتور منتصر عندنا 2 methods في ELISA في IHA. Both are accepted as #1 tests. When you have high titer, for high with respect to the number, when you treat, honestly, it's difficult to use them, which I don't routine at all. It's difficult to use them as a follow-up, like for example, the Bosilla titer after 1 year and others. Okay. Sorry.
I agree.
Any more questions or comments, Dr. Azam? Dr. Azam,
My question for the ID doctors, medical therapy after surgical excision, is total excision or rupture then aspirate? Any difference?
Sorry, I missed.
Yeah.
Medical treatment.
Yeah, medical treatment post surgery.
Yes.
For both if it's complete excision or rupture.
Yeah, and the studies have shown a higher or a lower rate of recurrence if you use combination surgery and medical. So even if removed in total, I would still recommend treatment.
For how long?
Yeah, probably 6 to 12 weeks.
Same because
But you start before surgery, right?
or if it's rupture.
I'm sorry?
I mean, if it's ruptured and they inject and then they remove the capsule.
If there's a
will be the
rupture
same?
and you have done the washing, I would continue for a very long time, maybe a year
Yeah,
at least.
So you will use the medical treatment
For longer
It will not rupture 3 months, it ruptures for 1 year.
And it's always preferable to start before surgery.
Yes.
A week or 2.
Thank you very much. We'll see you, Dr. Azam. Yes.